Why don't we get started? Welcome to Medical Grand Rounds. Hope you all had a great Thanksgiving and didn't connect with too many people, but got some family time. As you know, we're in the midst of wave 2. So I thought it appropriate to spend a few minutes talking about epidemiology and treatment. So without further ado, Dr. Lesho already has his first slide up. We can go ahead and start with the epi update.
Thank you, Dr. Phatak. Good morning, everybody. So the bottom line is it's bad and deteriorating quickly. 2 weeks before Thanksgiving, there was a 27% increase in the number of positive cases across the state. There was a 257 increase in Monroe County alone. Over the last 4 days, we've had more than 500 new positives a day. So 2,000, totaling 2,000 cases. You know, it's almost like the word unprecedented is becoming meaningless. I think record-breaking is heading in the same category. We break records almost every day. So there were 600 positive cases in Monroe County yesterday. There's over 200 patients across our system in the hospital with COVID and the similar number at university system. And Dr. Mayo and the team there are working closely with our colleagues at University of Rochester for what you heard the governor say about load balancing. So that one system or hospital isn't overwhelmed. That's what they're working on. The rolling average, if it stays at these levels, orange zone will be red shortly and yellow zones will be orange. The city and the surrounding communities are attempting to set up rapid testing sites for asymptomatic testing for people to go without doctor's orders, but you know, they're fraught as well. Sometimes one had all the tests accounted for just right about at the time it was open. So more to follow on that. Here's a daily breakdown for those of you that don't have access to the click view or the daily report. So you can see by hospital the number of new cases that were there on the 2nd, the 10-day summary, the 3-day summary, and then down in the lower right is the metrics for long-term care. I put this slide in for perspective across the pandemic. So it goes from the 13th, 14th of March. You see how much different the curve is this time towards the left of the bottom screen, the right, I mean. And so you see how much larger we are. So to date, we almost have 270,000 tests performed in our system. And you can read the number of positives as well there to the right. We work closely again with both systems and Donna Newhart and the team, and they do projections, and the projections are similarly concerning. You could see there we continue to exceed various stages of our surge triggers. But what does that mean numerically? Okay, so as I said, there is over 200 patients in our system right now. So we're right now to get, you know, December the 7th, the best case scenario is about 230 some hospitalized in our system. We're close to that now. And so, you know, that you can see the worst case scenario. Worst case scenario, the projection is that by Christmas, we're looking at almost, you know, the same number of patients that are in our system now, twice that is a projected. And so far, the last couple of projections recently, they're getting more accurate, and their confidence intervals are getting narrower and narrower. We've had some, I want to bring your attention to the false negative rate, because we've had some exposures that we're currently working on various wards where the patients were tested negative. They tested negative on admission, and ultimately were testing positive various time frames afterwards, from 2nd days to 3 or 4 days, but most of those were within the window of the incubation period. So if it's beyond 14 days, then it's a hard hospital onset, but it's less than 14 days, they could still be in the incubation period. And so this is a really nice article. I call your attention. Just you recall, if you have patients that have typical symptoms and the symptoms are protean, it can include fever, it doesn't have to include fever. Just because you have a single negative tests, be careful with it, okay? If you don't have a firm alternative diagnosis, and this, it's challenging. I'm not saying these were easy cases. Almost all of these cases had plausible alternative diagnosis. And where we're seeing it a lot is in the cardiac wards, right? So we know that COVID increases cardiovascular risk events for that. But the patients have a history of shortness of breath, difficult, and how it's hard to tease that. If you're not really comfortable with it, get another test. I mean, how many tests do you have to get? I mean, I think 3, but I wouldn't get it right back to back. I'd let it at least a day go in between. In fact, this is another great article from the New England Journal of Medicine that shows how the sensitivity and specificity of the test affects your threshold for the probability, the pretest probability. And we don't have time to go into that. And here's an article from the Mayo Clinic about some recommendations to mitigate the false negative. And these slides will be available through Lisa. So again, I want to keep this to 5 minutes or less. And relative to this is how hard it is to control this. And this has been nicely demonstrated by 2 articles in the New England Journal. I mean, you can't get a more restricted and controlled environment than in the military academy and then on an aircraft carrier. And what they showed us, you can read the details there. Almost 80% had no symptoms when they tested positive. And almost, about half only ever developed symptoms within the study period. So we are aware of pre-symptomatic transmission, asymptomatic transmission, but it's a challenge. Because the lab is doing an awesome job. We're still pretty much maintaining a turnaround time for exposed employees, less than 36 hours, maybe 48 at most. But there's always a speed bump given the ultra shortages of testing reagents and supply. So I just put, and then the next one here is a military. These cadets underwent constant supervision 24/7 by the drill sergeant. They had PCR every week. And they kind of no instructors were positive, and they were on a 2-week lockdown period. So they weren't visiting, they weren't traveling. Right off the bat, asymptomatic, before they even started on the first time around, when they inducted them into the academy, 10% of there were positive already. 2% became positive. Every 2 weeks, you'd get 2 more percent, no matter what you did, how strict the environment was. The only time they didn't wear a mask is when they were eating and sleeping, basically. And they point out that no case was identified by a symptomatic screening. So I just leave you with that. And that's the diagrammatic of what was related to what, which is kind of analogous to the room outbreak trend or the sequence, the unfolding that we see on some of the wards, especially 7800 and so forth. We're making inroads into doing high resolution genetic fingerprinting. We're trying to collect isolates. We are collecting isolates from positive patients in the nosocomial outbreak arena and attempting to compare those to any staff samples that we get. And so more to follow on that, but we are learning more. We know what the mutation rate is, and so that helps us do outbreak investigations a lot. And so finally, I want to end up, I know everybody's excited about the news about the vaccine. Early on, Dr. Laguio and Dr. Walsh and Fauci, they've been working at this, enrolling patients from the very start. In addition to that, over the last several weeks, the incident command team and others are hard at work behind the scenes with logistics preparation. The good news is there's at least, I last counted, 15 of these ultra cold freezers, either being distributed across our healthcare system. But that said, it's going to be limited initially, and you heard on the news about the priorities. So don't expect to have all healthcare workers or all patients immediately vaccinated. Again, I remind you the false negatives, outbreak investigations underway. Why we're seeing a lot of positive employees, why we're seeing a lot, you've heard it on the news, living room spread. But what we're seeing at work is be careful in the break rooms. We're harder and harder, it gets worse and worse in terms of you can't chat with your colleagues anymore. Can't decompress at the water cooler or have a quick lunch, so be careful. Break rooms are small, they're crowded, they've been associated with some employee spread. Finally, encourage your patients to wear a mask, okay? We want to get that. And, an easy selling point is it protects them. just yesterday alone, 6 patients became positive on a ward that, you know, that might have been a little bit mitigated had the patients been more adherent to that. And with that, I'll turn it over to Dr. Laguio and stop sharing.
There are a couple of questions that popped up. I don't know if you want to take a minute now.
Yeah.
One is about N95 masks and whether we should be using those more. And the other is, what about people who are recovered from coronavirus? Should they wait for the vaccine?
Any staff that feels like they should use, they want to use an N95, we encourage that as long as they, you know, we can't burn through them. We have to be good stewards of the PPE. I know infection prevention is looking at some revisions to the policy, allowing more liberal use of N95s. If you're going to wear the N95s, you know, you use the extended use guidelines appropriately, use the face shield. And so, yeah, I would, you know, I would encourage people to make sure that when they're aerosolizing procedures involved, they're using N95s. And in terms of the other question for the vaccine, that is to be determined yet, as to if you had it. The question was, if you had COVID, should you get the vaccine? I have to defer to the you know, the others on that one.
All right, so I will try and be as efficient as possible. And I was asked to present information about the monoclonal antibodies. I am sorry it's not about vaccines, but you know, every day there is new information. So as I will assume that in healthcare we're familiar with monoclonal antibodies, and the premise is that you know, we can manufacture antibodies or proteins that are very specific to mimic or augment our immune systems in very specific ways. So these monoclonal antibodies for COVID are designed at this time to target the spike protein. And the spike protein are what the virus uses to attach to the ACE2 receptor on human cells and then gain access, entry, and viral replication. By putting on these monoclonal antibodies, it blocks the engagement with the receptor and then therefore blocks the infection and entry. So there are several monoclonals that are being studied, and the two that have recently been given emergency authorization is bamlanivimab, which is produced by Eli Lilly, and casirivimab with imdevimab. So just for ease, I will call the second one the Regeneron cocktail. Are you seeing my slides? Okay, wait. I don't know why this isn't working.
We're seeing the slides. You can just advance them.
Oh, there's the advance. Okay, so this is part of a greater network within the NIH where they wanted to recruit a partnership between the public as well as government and research enterprises. And so this framework is of these 5 levels called the Accelerating COVID-19 Therapeutic Interventions and Vaccines Trials. And so you could see active 2 and active 3 focused on the monoclonal antibodies, and they were outpatient or inpatient populations respectively. There is very limited data that is public and reviewable, and there was only one currently peer-reviewed published trial that was on the topic of outpatient therapy with BLAZE-1, which I'll go to next. But I wanted to start with the inpatient because I think it's important to know that these were evaluated, and both studies were actually halted early. So to start, BLAZE-2 compared remdesivir combined with bamlanivimab versus remdesivir with placebo. And there are regular evaluations of the data as it comes out. And on October 13, the independent DSMB found that there was potentially a safety concern in the intervention groups. They decided to halt the study. And then continuing follow-up 2 weeks later for the continued evaluation, they ultimately wound up stopping the trial because it was felt there's a low likelihood to determine any efficacy. Of note, there weren't any additional safety concerns in the final conclusion for stoppage, but I think it's interesting that at least for inpatients, there was concerns that it wasn't likely to change or be clinically meaningful. For the Regeneron cocktail, this trial similarly was halted due to potential safety concerns and unfavorable risk-benefit profile. I wish I could be more specific, but currently the information that's available on the public level is only through either the NIH website or the drug company's website, but there's no granularity I can provide for you at this time. But there is a bit more for the outpatient monoclonals, and there are 2 trials for each of these monoclonals that had very similar inclusion and exclusion criteria, which are in the yellow, and then very similar clinical endpoints. So first off, for outpatients, this needed to be someone who is in the outpatient setting with mild to moderate symptoms. They had a symptom scale survey that they would take on eligibility screening. And ideally, the symptoms were not present for more than 10 days. They also had to have confirmed infection with SARS-CoV-2 via either an antigen or a PCR test within 3 days of the planned infusion. Of note, they did not include anybody who had hypoxia, but they did strive to enroll individuals, at least 50% of the population, who had significant risk factors for severe COVID or hospitalization. And these are very broad. So it's either age greater than 65, BMI greater than 35, chronic lung disease, chronic heart disease, chronic kidney, immunosuppressive medications, et cetera. So just to orient you to the slide, so these will be all the outcomes for the BLAZE-1, and the outcomes that are in red regard the bamlanivimab, and the black are the placebo. And then down here is the Regeneron cocktail. So the primary endpoint for both studies was the impact on serial nasopharyngeal swabs and the viral load by day 11. And they found that, so the BLAZE-1 was 4 arms and roughly 100 individuals in each arm. And then in the Regeneron cocktail is 3 arms, placebo versus 2 doses and roughly 250 in each arm. The viral load decreased by day 11 in all groups, regardless if they had the intervention or not. They noted that there was a slightly faster decrease in individuals who received the 2,800 milligram dose. And in the language of the article, it found that although this was significant microbiologically, it didn't seem to pan out that there was a dose response in terms of outcomes clinically. And then I know this is small, but this is just also similar. You could see with this monoclonal, the trend to decrease viral load here is in the blue for the placebo. And there was a more rapid but similar rate of decline in those who were in the intervention group. Looking at secondary endpoints, for symptom resolution on day 11, it was overall faster. They don't have specific days in terms of how fast those who received the monoclonal got better, but all had symptom resolution by day 11. For Regeneron, it was 5 days since infusion to feel completely recovered versus 6 days for those in the placebo group. For hospitalizations and 29 days in follow-up, BLAZE-1 looked specifically at hospitalizations. The Regeneron cocktail looked at hospitalizations as well as visits to ED or urgent care or unplanned medical attention via telehealth, et cetera. And they saw that those who received the monoclonal did have a significantly lower incidence of hospitalizations in the subsequent month. And you can see the numbers here. And both groups did a post hoc analysis looking at those individuals that had risk factors. In the publication for BLAZE-1 that came out at NEJM, they comment that the risk factors which seemed to have the most impact were those who were greater than age 65, as well as a high BMI. And there's no further details about the other risk factors and the potential impact. And then overall adverse events seems to be relatively safe. There were equal numbers of adverse events, primarily nausea, vomiting, diarrhea, between the monoclonal as well as the placebo. There were slightly more infusion reactions, which did not need to be medically attended in the BLAZE-1. However, in the Regeneron cocktail, it was noted that there was one case of anaphylaxis that did require epinephrine and attention. So on this preliminary data, the FDA gave EUA to bamlanivimab on November 10, and then on the 21st for the Regeneron cocktail. And the EUAs are pretty much identical in who the indicated patients potentially could be. So, it's people with mild to moderate COVID-19 who have positive results and are at high risk. It specifically notes it's not authorized for use in people who are hospitalized due to COVID or who require oxygen therapy due to COVID or a higher amount of oxygen over their baseline need. But when you think about this, like, who does this really apply to? So, and there's some logistics that it would be just kind of probably necessary to mull over. So we need an individual who has confirmed disease. And, we have talked about the challenges with access to testing or turnaround times. And there is some time sensitive nature to this because they should be sick, but not longer than 10 days. And they can't be sick enough to warrant hospitalization and not sick enough to need oxygen or more oxygen. And they should still be symptomatic within the 2 days of getting the infusion. So you have a very stringent spectrum of disease for COVID. Meanwhile, you have a very broad range of potential people who could be considered at risk. I'm sure many of us could note off the top of our heads, half a dozen of our personal patients that could qualify for this if they get diagnosed with COVID. So just kind of thinking about this though, like, how would we bring this off the ground as a healthcare system? And so there are a couple challenges that our groups, as well as many have discussed along in infectious diseases like listservs. Well, first is the limited supply. In terms of the distribution, there has been a plan for distribution of the monoclonals to healthcare systems. And when you get to the actual volume, there may be more people who are positive in a single day than the amount of drug that you receive in your first shipment. And so if you have very small amounts, like, who makes the decision of who gets what and when? How can we be cognizant of health inequities and promote justice so people have an equal opportunity to access these medications? And then next, there's a lot of location logistics. This is an hour-long infusion. And so you wonder, like, well, are there infusion centers? The idea was to prevent hospitalizations and not take up beds from sicker individuals. But a lot of infusion centers already have a high proportion of immunocompromised hosts. So you'd have somebody who has early COVID and they are highly infectious at that time. And I don't know if you would want to put them in a waiting area, an area where you have many immunocompromised individuals that they could contact. Ideally, the infusion centers or location that they would receive their infusion would be a negative pressure room. If you would know that this patient is coming in. So by protocol, somebody should ideally meet the patient at the institution's entrance, provide them, make sure they're masked correctly, escort them directly to their negative pressure room, make sure they don't wander off to the cafeteria or in the bathrooms or anything, and get themselves situated. And then, when they're there, this drug does require pharmaceutical skill to mix it. It can't just be on the shelf. It's refrigerated and then comes to room temperature and then it's prepped. And then the patient's in the chair. It's an hour-long infusion, and it requires a 1 hour-long post-observation monitoring. And as well, the center needs access to emergency medical systems if necessary. So it's a long chair time. And I can't speak to the challenges of this amount of time or setting up urgent referrals for infusion centers, but I can imagine that this can be tough. And then, there's terminal cleaning to follow. There should be staff that's trained. There should be adequate PPE regarding these patients' care. And then even afterward, there's the aftercare. There should be some monitoring by the individual's primary care physician or other physicians to ensure that, this was effective in them, that they did not progress to more severe COVID. The EUA does require that if there are any adverse events, they should be reported. This is it's not a fully approved medication. We still need to learn more about the safety as well as the efficacy. So while adverse event reporting is required, overall patient positive clinical outcomes is not. But we probably need to think about, are there registries that need to be developed so we can still gain knowledge from this use? So I think that in going over this, as this is a promising yet challenging medication to administer to a lot of patients that could potentially be eligible. and where could be some great roles for this monoclonal. There have not been published studies yet, but there are ongoing studies on the role of prophylaxis. One of the BLAZE trials is looking at administration in nursing homes if there is an identified person, whether it's a pre-exposure or post-exposure prophylaxis. We're all excited for the vaccine, but not everyone is eligible for the vaccine. So could this be something that we could give to someone who would be ineligible? Or people who are vaccinated but high risk, but you're still waiting for seroconversion. There's 3 weeks in between your 2 doses, and you still have to wait for the person's innate antibody response. And then there are poor vaccine responders. So a couple considerations that as providers we should start thinking about and discussing, because these are not the only monoclonals that are being evaluated, and there's likely more to come. So I really appreciate this opportunity, and thank you.
So yeah, I think we need to develop the infrastructure to administer these antibodies to the few people who really qualify. We should talk about that offline. And if people have other questions, I would suggest email Dr. Lesho or Dr. Laguio-Villa. And with that, we have Dr. Baibhav.
Hi, good morning. Thank you for this opportunity. Over the next 30 minutes, I will try to cover some of the basics regarding hypertrophic cardiomyopathy, and also talk briefly about the Hypertrophic Cardiomyopathy Center at Rochester Regional Health. I have one disclosure which is not pertinent to this talk. So what we are going to talk about is the prevalence and pathophysiology, symptoms, diagnosis, some of the treatment modalities, and then we'll also delve briefly about the comprehensive hypertrophic cardiomyopathy centers and our center. So this is a schematic showing a layman's view of hypertrophic cardiomyopathy. So the normal thickness of the left ventricular wall is up to 11 millimeters. And the traditional definition for hypertrophic cardiomyopathy is when there is thickening of the left ventricular wall without an obvious cause. So in a patient who does not have uncontrolled hypertension or does not have aortic stenosis, a thickening usually more than 15 millimeter is consistent with hypertrophic cardiomyopathy. Most commonly, the LV is involved, but sometimes we can see biventricular involvement as well. And this septal wall, which is the wall between the right ventricle and the left ventricle, is the most common cause, common area of hypertrophy. So it is one of the most common genetic heart diseases. It is a disease of the sarcomere proteins of the heart. There is a lot of genetic heterogeneity, which I will talk about. And then there is variable penetrance and expression. So even in the same family with the same genes, the penetrance is different, and the expression or phenotypic expression of hypertrophic cardiomyopathy might be different even in the same family carrying the same gene. It has diverse clinical manifestations. In some patients, it may be completely silent and go undetected throughout their life. But in other patients, they can manifest with symptoms in the pediatric or at a young age. So the traditional definition of hypertrophic cardiomyopathy is increased left ventricular wall thickness, which is not explained by any other cause. Usual diagnosis is made when the thickness is more than or equal to 15 millimeter. It is associated with cellular changes, stiffening, and abnormalities of the mitral valve, which many times accompanies hypertrophic cardiomyopathy. Patients with hypertrophic cardiomyopathy may have obstruction, both LVOT, left ventricular outflow tract obstruction, or mid-cavity obstruction, or even apical obstruction. And the obstruction many times may not be present at rest, but when we ask them to exercise or do a Valsalva or standing, or give them inhalational amyl nitrate, the occult obstruction may get manifested. So this is kind of very important, especially for a hypertrophic cardiomyopathy center to try to bring out the obstruction in patients who may not have that at rest. So the prevalence of hypertrophic cardiomyopathy, some of the older studies, this was the Cardia study, which suggests the prevalence of 1 in 500, but prevalence actually may be even higher because now with genetic testing, as well as with advanced imaging, both with echocardiography as well as with cardiac MRI, we are finding more and more cases. And now we think that the prevalence may be as high as even 1 in 200. So it is one of the most common genetic heart conditions. And it is a disease of the sarcomere protein. So here is a schematic of a sarcomere composed of thick and thin filaments. And Z discs is depicted here. And what we see is in patients who carry, basically 8 or 9 genetic mutations have been implicated in hypertrophic cardiomyopathy. And most commonly, we find mutations in the myosin binding protein C or the myosin heavy chain. So this is the most, these are the most common mutations we find. So in our genetic panels now, we include all these genes, but we also look for some of the mimics of hypertrophic cardiomyopathy, such as cardiac amyloidosis or Fabry's disease. Around 40 to 50% of the patients, when we test them for genetic mutations, will have a pathogenic or a likely pathogenic mutation. 40-50% do not. Many are variants of uncertain significance. And as we get more data, sometimes these variants can be reclassified in a few years as likely pathogenic or pathogenic. What are the symptoms of hypertrophic cardiomyopathy? It can be asymptomatic in many patients, but patients can have shortness of breath, fatigue, chest pain. Sometimes they may even have postprandial symptoms. So what happens is if they have left ventricular outflow tract obstruction or have a really thickened myocardium, after eating, they may get a splanchnic vasodilatation with decreased preload to the heart, and which may worsen the obstruction or cause them to have more shortness of breath. And it can also result in palpitations. So the common arrhythmias we see is not only NSVT or VT, but also atrial fibrillation is quite common in these patients. Lightheadedness or syncope is kind of a dreaded complication, which may be because of ventricular arrhythmias, but can also happen if the patients have a lot of obstruction, leading to decrease in blood pressure with exertion and causing them to have a syncope. End-stage hypertrophic cardiomyopathy, which is not very common, but seen in 3 to 4% of patients, where there is decline in left ventricular ejection fraction less than 50%, can lead to symptoms of heart failure with edema. So what are the causes of symptoms? So the causes of symptoms can be related to left ventricular outflow tract obstruction. Most of these patients who have left ventricular outflow tract obstruction also have mitral regurgitation from systolic anterior motion of the mitral valve, which can lead to progressive shortness of breath, left atrial dilatation. Diastolic dysfunction is very common. So some of our most challenging patients are patients who do not have obstruction, but have a very stiff heart, thickened muscle, elevated filling pressures, and they have diastolic dysfunction. Concomitant coronary artery disease always must be taken in consideration in patients who are older and who have risk factors for coronary artery disease, because we don't want to miss this as a cause of their symptoms. And many times we see that even in the absence of epicardial coronary artery disease, these patients have microvascular ischemia, which means the demand is unable to meet the supply. So the myocardium is quite thickened, and especially sometimes even at rest, but mostly at exertion, they might get chest pain symptoms, which is not related to epicardial coronary obstruction. And arrhythmias such as atrial fibrillation fibrillation, non-sustained ventricular tachycardia, and ventricular tachycardia are also can result in symptoms. The complications, sudden cardiac death from sustained ventricular arrhythmias or ventricular fibrillation. Arrhythmias, atrial fibrillation. Wolff-Parkinson-White syndrome is associated with hypertrophic cardiomyopathy and ventricular tachycardia and ventricular fibrillation. And as I said, heart failure and end-stage hypertrophic cardiomyopathy. It also must be remembered that among the young, and this is data from US athletes, hypertrophic cardiomyopathy was responsible for around 35% of sudden cardiac death in young people. So hypertrophic cardiomyopathy is in North America the most important cause or most common cause of sudden cardiac death in young people. When we look at hypertrophic cardiomyopathy, sometimes things phenotypically on echo, it may appear that they have hypertrophic cardiomyopathy related to diagnosed pathogenic or a likely pathogenic mutation. Sometimes 30-40% of the time we don't know, but we have to also keep in mind some of the rarer things that can look like hypertrophic cardiomyopathy, which are phenocopies but are not hypertrophic cardiomyopathy. We are recognizing more and more cardiac amyloidosis. Sometimes there is drug-induced hypertrophy, hypertension. Athletes' heart are also causes of LV hypertrophy. So our goal in reviewing history, imaging, EKG, and all the advanced techniques that we have is to try to distinguish a true hypertrophic cardiomyopathy from some of these phenocopies. So some of the common mimics are hypertension, which can lead to LV hypertrophy, rarely more than 1.5 centimeters unless the blood pressure is really uncontrolled. Athlete's heart, which can lead to LV hypertrophy, but usually the degree of hypertrophy is not more than 1.5 centimeters. Aortic stenosis can lead to hypertrophy. Subaortic membranes and subaortic stenosis can lead to hypertrophy. Cardiac amyloidosis. Drugs can lead to LVH and can mimic hypertrophic cardiomyopathy. We had a recent case where we identified Fabry's disease, and then inborn errors of metabolism. Usually they manifest in the pediatric age group or by early teenage years. So the diagnostic tests that we use are EKG. We get echocardiogram is our first line of imaging. We use biomarkers, especially troponin. Sometimes these patients can have mild degree of troponin elevation, which is chronic, which is related to the thickened myocardium and chronic microvascular ischemia. NT-proBNP levels are very important because they tell us about the prognosis in these patients. So patients who are younger and have an elevated proBNP level, which may be because of LVOT obstruction, but also portends a worse prognosis long-term. Some of these patients may end up having end-stage heart failure in the future and may need a heart transplant. We routinely do stress echocardiograms in these patients to look at obstruction with exercise and also evaluate exercise capacity and diastolic function. Cardiopulmonary stress tests are frequently employed in these patients. Cardiac MRI, transesophageal echocardiogram, cardiac catheterization, and we recommend genetic testing in all these patients. We work very closely with Kimberly Provenzano, who provides excellent services for these patients in terms of genetic testing and education. In the office, one of the clues to hypertrophic cardiomyopathy may be an abnormal EKG when there is no history of significant hypertension or in a young patient. And what we see here is LVH with repolarization changes. So if there is no history of significant hypertension, that should be a clue to thinking about hypertrophic cardiomyopathy. These LVH with deep T-wave inversions in the lateral and inferior leads very common finding with apical variant hypertrophic cardiomyopathy. So sometimes when we look at EKGs in absence of hypertension, that may be a clue that these patients have hypertrophic cardiomyopathy. In cardiac amyloidosis, typically the voltage is going to be low. That can be a that can help us discriminate based on EKG which way our diagnosis should be geared to. So this is these are cardiac MRI images. So this is a video image, what we call a 3-chamber view of the heart. So this is actually a normal heart. And what you see here is the aorta. This is the right ventricular outflow tract. This is the left ventricle. This is a nice normal heart with normal thickness. Unlike this normal left ventricle, what you see here is a patient with hypertrophic cardiomyopathy. What you see here is there is basal septal hypertrophy. So this is the septal wall here. Which is considerably thickened compared to the other segments. So there's asymmetric basal septal hypertrophy. The other thing that we note is during systole, this is the mitral valve, this is the anterior mitral leaflet, and this is the posterior mitral leaflet. And what we see is during systole, the anterior mitral leaflet is dragged anteriorly towards the septum, creating a jet of turbulent jet in the left ventricular outflow tract, which is consistent with LVOT obstruction. We also see a mitral regurgitation related to the systolic anterior motion of the mitral valve, where there is a posteriorly directed jet of mitral regurgitation. So a classic finding with asymmetric septal hypertrophy, left ventricular outflow tract obstruction, and posteriorly directed jet of mitral regurgitation. So again, this is systole when the heart is kind of smaller, and what we see is that the anterior mitral leaflet is almost touching this septum here. So echocardiogram is our first line of imaging. It provides excellent evaluation of LVOT obstruction, diastolic function, mitral regurgitation, and we also look at the structure and function of ventricles. So sometimes things are very obvious. So in this case, as we see, there is massive left ventricular hypertrophy. There is the right ventricular hypertrophy as well. This is the mitral valve. This is the tricuspid valve, and what we see is that there is hardly any LV cavity. So this is extremely hypertrophy. And when we do our color Doppler images, what we see is there is systolic anterior motion of the mitral valve. There is hardly any space in the left ventricular outflow tract. What we see is this posteriorly directed jet of mitral regurgitation as well as LVOT obstruction. So sometimes things can be very obvious, but sometimes it is not. So here, these are non-contrast images of the LV. It's hard to say what's going on, but when we inject microbubble contrast, we can see that there is a spade-shaped heart. So the heart is spade-shaped, and there is thickening of the apical segments, consistent with, this is a mild form of apical hypertrophic cardiomyopathy. These are just TE images showing beautifully the systolic anterior motion of the mitral valve. So this video, this is the septal wall, this is the mitral valve, this is the left atrium here, and what you see here that there is systolic anterior motion of the mitral valve. So so this is systole, and what we see here in systole is this anterior mitral leaflet is touching the septal wall. So this causes turbulence in the left ventricular outflow tract leading to LVOT obstruction. And because the anterior mitral leaflet is kind of dragged towards the septum, there is actually an abnormality of the mitral valve apparatus, and there is mitral regurgitation this way. So when we look at color Doppler images, we can see the lot of turbulence in the left ventricular outflow tract and this posteriorly directed jet of mitral regurgitation. And this is an example of a patient who does not have hypertrophic cardiomyopathy. We don't see that. Hypertrophic cardiomyopathy is also associated with a lot of abnormalities of the mitral valve. So not only there is systolic anterior motion of the mitral valve, but we have anterior mitral leaflet, which can be lengthened. So in this case, this anterior mitral leaflet is long and redundant, and we can also have abnormalities of the papillary muscles. So this is an example of what we called a dynamic LVOT obstruction. So what we can see is a dagger shape. So this is systole, this is the QRS. So this is systole. So you can see a mid to late systolic jet of obstruction with a peak gradient of 92 millimeters of mercury in the LVOT. So quite a lot of obstruction in this patient. These are the different morphologies of hypertrophic cardiomyopathy. This is a simplified version, but any segment of the left ventricle can be affected. Sometimes it may be just one or two segments that are hypertrophied. So for example, in this case, we have what we call the sigmoid morphology of hypertrophic cardiomyopathy, where there is this basal septal segment that's hypertrophied. Here, this is the reverse curve hypertrophic cardiomyopathy, where actually the bulging is so much that the LV cavity is concave, and there is massive hypertrophy. This form of hypertrophic cardiomyopathy has high likelihood of finding a pathogenic or a likely pathogenic mutation. This is apical variant hypertrophic cardiomyopathy, and where there is thickening at the apex. And then this is neutral hypertrophic cardiomyopathy, where there is thickening of kind of all myocardial segments. This is hypertrophic cardiomyopathy, where there's just sigmoid septal hypertrophy. So we just see the other myocardial segments are fine, except the sigmoid shaped septum, and then there is evidence of dynamic obstruction, LVOT obstruction. If we do a cross section like this, getting a short axis view, what we see here is again thickening at the basal septal wall, while the other segments are normal thickness. And then this turbulence here at the mitral valve level is the systolic anterior motion and the LVOT obstruction. This is a patient who underwent septal myomectomy. What we see here is a lot of thickening of the heart muscle, concave LV cavity. She was very symptomatic. We also see dynamic LVOT obstruction here and systolic anterior motion of the mitral valve. She underwent septal myomectomy and is doing well. This is apical variant hypertrophic cardiomyopathy, an example of apical variant hypertrophic cardiomyopathy, where we actually see that the basal segments are normal in thickness of the LV, but the mid to distal segments are hypertrophied, and actually there is a small apical aneurysm. And this small apical aneurysm is because of the mid cavity obstruction from this. There is some chronic ischemia of this apical segments from the mid cavity obstruction, leading to scarring, and that can be a trigger for ventricular arrhythmias. That area of scar can be a trigger for ventricular arrhythmias. This is an example of a neutral hypertrophic cardiomyopathy, where there is diffuse thickening of all segments, and you can see again the systolic anterior motion of the mitral valve and posteriorly directed jet of mitral regurgitation on dynamic LV obstruction. Scar imaging with MRI is extremely important because diffuse and extensive scarring has been associated with increased risk of ventricular tachycardia or ventricular fibrillation. And these images are acquired after administration of gadolinium. And the reason for scarring in hypertrophic cardiomyopathy is not very well understood, but it is related to myofibril disarray and probably chronic ischemia related to microvascular dysfunction. So the areas of black are normal, but the white areas is all scar. So here we see a lot of scar in the septal wall, the mid septal wall, while here in this patient there is diffuse kind of patchy scar in all segments of the myocardium. So this patient and this patient both have significant scar burden. which can be associated with increased risk of sudden cardiac death. Rarely we encounter, but sometimes we do, end stage or burnt out hypertrophic cardiomyopathy, where the LV function is actually declined to less than 50%. So in most patients with hypertrophic cardiomyopathy, the LV is hyperdynamic. But as we can see in these images, there is a lot of wall motion abnormalities. The LV is not squeezing well. The contractility is significantly reduced, and there is a lot of scarring on delayed enhancement imaging in the septal wall, here in the anterior wall, inferior wall. So this patient had burnt out hypertrophic cardiomyopathy and was listed for transplant. We do a lot of physiological testing. So this is a patient who has hypertrophic cardiomyopathy, and these are rest images. And these were just with Valsalva. What we see is there is a lot of mitral regurgitation just with the Valsalva maneuver. So what happens with Valsalva is there is decreased preload to the heart, worsening LVOT obstruction, and a lot of severe mitral regurgitation. This is a stress echo example. So this is before exercise. This is after exercise. You can see that the heart rate is 54 beats per minute. This is before exercise. And then this is after exercise when the heart rate is 110 beats per minute. And what we see is the gradient across the left ventricular outflow tract was 36 millimeters of mercury here, but with exercise, this gradient is more than like 150 millimeters of mercury. So with exercise, really a lot of obstruction, and the patient was very symptomatic and underwent septal myomectomy for relief of symptoms. Not uncommonly, we also encounter other etiologies. So this is a patient who had LVH, has small pericardial effusion, and on scar imaging has this diffuse hyperenhancement consistent with cardiac amyloidosis. So this patient did have hypertrophic cardiomyopathy, they had cardiac amyloidosis. Then subaortic stenosis. You can see in these images, there's a little nub in the subaortic area. There's no systolic anterior motion of the mitral valve, but there is flow acceleration in the left ventricular outflow tract, and that was related to subaortic membrane and not hypertrophic cardiomyopathy. So the role of imaging is very critical to diagnose true hypertrophic cardiomyopathy, but also to identify some of the mimics, because the treatments will be different. Heart catheterization, we evaluate for filling pressures. We sometimes do right heart catheterization with exercise. And obviously, we evaluate the coronary anatomy and evaluation of coronary artery disease in certain patients. So management, I do not have much time, so I'm going to just go over quickly. Many patients may be asymptomatic. 30% of the patients do not have obstruction, and 60 to 70% may have obstruction at rest or with provocation. So it's very important to tailor treatment strategies based on symptoms and based on what is causing the symptoms. So for patients who have obstruction, preload is extremely important. So we ask them to avoid dehydration, avoid excessive alcohol, if they have postprandial symptoms, to have small frequent meals. And most patients can do low or moderate intensity exercise, but we ask them to avoid high intensity sports. Afterload reducing agents such as vasodilators, nitrates, angiotensin converting enzyme inhibitors, ARBs, and diuretics are kind of contraindicated because they can worsen preload and worsen the obstruction. If patients have heart failure symptoms, we use diuretics, but we are cautious. The first line therapy for obstruction is usually beta blockers or calcium channel blockers. In certain patients, we can also use Norpace. There is this new drug called mavacamten. And there was this recent study which was called the Explorer Multi-Center International Study, and this was on this molecule mavacamten, which is a small molecule selective allosteric inhibitor of cardiac myosin ATPase, which specifically targets underlying pathophysiology of hypertrophic cardiomyopathy. So beta blockers, calcium channels blockers do not work on the underlying pathophysiology of HCM, but this drug does. And it reduces actin-myosin cross-bridge formation and reduces contractility and improved myocardial energetics. So what we see is these were patients with obstruction, and we look at the resting LVOT gradient, and with medication, with mavacamten, there was significant reduction in resting LVOT gradient at rest, and also with exercise, there was significant reduction in post-exercise gradient. So this is an exciting therapy, but there are more trials going on, and hopefully in the next year or two, we may have approval for this drug, so which may provide a non-invasive option for treatment of these patients who have not responded to beta blocker or calcium channel blocker therapy. With this drug, there was also significant improvement in NYHA functional class, along with pro-BNP levels and 6-minute walk tests and cardiopulmonary stress tests. So this is exciting. If patients with hypertrophic obstructive cardiomyopathy develop hypotension, we need to make sure we give them fluids, avoid inotropes, and if we need a pressor, we need to use phenylephrine. SCD risk, I'm just going to go to the 2020 guidelines. So if patients have sustained ventricular fibrillation or sustained VT, an ICD is recommended, but then we look at, for primary prevention, family history, massive LVH, if they have unexplained syncope, if they have apical aneurysm, and if the EF is less than 50%, then the ICD might be reasonable. Sometimes if they have bursts of NSVT, long episodes of NSVT on monitoring, we sometimes consider an ICD, and if they have extensive LGE on CMR, it can be a discriminator for an ICD. Extensive fibrosis. Bottom line is there is no holy grail for deciding who needs an ICD. The European guidelines, which were done in 2014, are not that sensitive, but are more specific. The American guidelines, which came out recently, are very sensitive, but a little less specific. So basically, we need to have a shared decision making about implanting ICDs for primary prevention in these patients, because especially these younger patients who have hypertrophic cardiomyopathy may have adverse events related to implantation of an ICD long-term, such as lead fractures, inappropriate therapies, infection, etc. Invasive treatment is reserved for patients who have failed medical therapy, and it can be either surgical septal myomectomy or alcohol septal ablation. In younger patients or who have a lot of obstruction, usually surgical septal myomectomy is the preferred approach. And then usually we meet as a multidisciplinary team to decide which approach would be the best for the patient and also consider patient preference. So briefly talking about our program, so RGH, obviously we have, RRH has a wide network, and we also now are in St. Lawrence in the Adirondacks, and we get kind of patients from all these areas. A hypertrophic cardiomyopathy center provides state-of-the-art facilities closer to home. We have a multidisciplinary approach. Since we are seeing a higher volume of patients, we get expertise. Our surgical outcomes are better. With alcohol septal ablation, and we really provide multidisciplinary care. Again, we provide all imaging modalities, cardiac catheterization, SCD risk assessment. We have an EP team. We have an advanced heart failure team. We provide septal reduction therapies, counseling, mental health. An important piece also is genetics, and we have a robust genetics program with Kimberly Provenzano. And we have a collaboration with Buffalo Children's Hospitals for pediatric patients, so our adult patients who have young children, they get screened and managed in collaboration with Buffalo Children's, and our pediatric cardiologist, Dr. Ori, is at Batavia, who sees patients once a month. We do have a registry to monitor our outcomes so that we are in line with the best in the country. And it's important that all comprehensive hypertrophic cardiomyopathy center have a 30-day mortality with myomectomy and alcohol septal ablation, which is less than 1%, along with some of these other outcomes. So far, this is data from end of last year. We had working on tabulating data from this year. We have not had any deaths. So our outcomes are in line with what is considered good around the country. These are our key personnel. Dr. Soon Park, who's chief of our cardiovascular institute, is our surgeon who performs myomectomies. Dr. Depta is our structural interventional cardiologist who does alcohol septal ablation. Dr. Chuprun is our electrophysiologist. Dr. Feitel is a heart failure cardiologist for patients who may need heart transplant. And we collaborate with Dr. Ori and Stephen Lifschultz in pediatric cardiology. We also collaborate with OBGYN team, Dr. Bostock, and our colleagues from cardiac anesthesia. And Dr. Rai, Buttar, and Tahir and Chaudhary been very productive with research and maintaining our registry. So this is our team. Luda Kuchma is our hypertrophic cardiomyopathy nurse practitioner. This is some of our information. So if we have a patient with hypertrophic cardiomyopathy or HCM spectrum disorder, as I like to call it, unexplained LVH, we'll be happy to try to tease out what the diagnosis is and address this in a multidisciplinary way. Thank you. Sorry, I went over by a few minutes.
No problem. We had you start late. So looking to see if there are questions, but most of the questions relate to COVID-19. I think we may bring those back next week. I'm not seeing any questions related to hypertrophic cardiomyopathy.
I must have done a nice job.
You must have done a fantastic job. So thank you very much. And we'll try to bring some of the COVID. Obviously, there's a hunger for information about COVID-19, and
okay, thank
you. Keep bringing those back. Enjoyed your presentation very much, and thank you all.